Hi, dentists again. This is Muhammad Musa from AFK Study Plan. Now we reached to the last part, is avulsion. Please watch the other two videos about the trauma, everything. There's a conclusion for everything. We speak about avulsion now. As usual, get your notebook, get your pen, make ready to get your notes, make your best to answer the question on the screen. It's extremely important. And feel free to share the video and give me your feedback. Okay? So here again, we're gonna not gonna go it again and again and again. We speak about it before, like about the trauma here. So avulsion. Now we speak about avulsion only, not everything. Reimplantation is in the most situation the treatment of choice, but cannot always be carried out immediately. Appropriate emergency management. Individual situation where reimplantation is not indicated is when severe caries or periodontal disease. You see the tooth is like useless, or uncooperative patients, severe cognitive impairment requiring sedation, several medical conditions as immunocompromised and severe cardiac condition, which must be dealt with individually. So, like to wrap it up, reimplantation is the line of treatment we're gonna use, unless there is like something like against it, like the tooth is useless, the tooth has a big cavity, the tooth has the patient himself is require more intervention, so you just don't do it. Okay, so here we go to scenario right away. So he will go in the article about the scenario. So you have two scenarios. The avulsed tooth, the patient has it, so you recommend him what to do. He called you, oh, my dentist, like I lost my tooth now. So what you should do, what you should tell him. So what you should tell him is this: keep the patient calm, ask him to pick the tooth from the crown, the white part. So we are speaking about a terminology that the patient can understand, and ask him to rinse it in milk, saline, or saliva of the patient and re-implant it in the original position. Yes, you heard it correctly. So the line of treatment here we're gonna do is ask the patient to do it himself. If he say, no, doctor, what you're saying, I cannot do it myself. So, okay, no problem. You ask him to come immediately to your office now and ask the patient to put the tooth inside the gauze and then store it. Store it in which medium? You store it in different medium. Like there is more than one recommendation for this, but usually you ask him to store it in milk or his own saliva. You ask him to put in the sulcus, buccal sulcus, but honestly, this is not reasonable. He might swallow the tooth, or this HPSS solution. And the old guideline was preferring HPSS over the milk, but here, as mentioned clearly, and this is the like. Let me show you here. This is the latest article. So before you might see a different article with different guideline. I understand this, but this is the latest article. It's saying like here in descending order of preference, milk is coming before HPSS. Saliva after spitting into a glass, for instance, or saline. Okay, so this is the point here. So reimplantation is the line of treatment you're gonna do. If patient called you, you ask him to do it again, to do it by himself. He cannot. You put it in milk and then come to you. Okay. So why are we doing this? Why are we doing this? Because like reimplantation is aiming to the tooth to be again inside the mouth. So the PDL is very delicate soft tissue in the roots. So minimizing the dry time is critical for survival of the PDL. After an extra of the dry time of 30 minutes, most PDL cells are non-viable. So you have three scenarios here. The BDL cells are most likely viable. The tooth has been reimplanted immediately or within a very short time, 15 minutes. This is a perfect scenario. The BDL cell may be viable but compromised. The tooth has been kept in a storage medium, milk or HPSS, or saline for total less than 60 minutes. Or the PDL are likely to be non-viable, and this is the worst case scenario. The total extra oral dry time has been more than 6 minutes, regardless of tooth having been stored in a medium or not. So storing in a medium is critical if it's less than 60. More than 60 and stored in whatever he stored it is not favorable, like it's not good. Okay, so the patient come to you like he was an amazing patient. He did reimplant the tooth at the site of injury. When he arrived to your office, verify the correct position, you take x-ray, make sure everything is good. And then if everything is good, amazing. If it's not good, so you try to adjust again. If it's everything is good, you may give him job offer to work with you. And then stabilize the tooth for 2 weeks using a passive flexible splint, such as a wire of diameter up to 16 inch or 0.016 inch or zero point 0.4 millimeter bonded to the tooth and adjacent teeth. Why I'm reading this? Because I want you to know this. Keep the composite and bonding agent away from gingival tissue and proximal area. Nylon finishing line can be used to create flexible splint. Okay, but the one we're gonna choose is stainless steel, and you should know these numbers, sadly. Okay. Oh, so to make sure you understand this point, every tooth avulsed going to be reimplanted. RCT is the final destination for it. You should do RCT anyway. Initiation for root canal treatment within 2 weeks after reimplantation. This is mandatory. You cannot say, okay, I'm not going to do RCT. There is no way. You should do RCT because the clinical outcome you are looking for, most likely it will be an enclosed tooth. And no problem if it's enclosed and root canal treated, so no problem here. So that's why we should use a splint from the labial side, because you're gonna do the RCT from the palatal side, okay? But if the tooth has been stored in the medium for less than 60 minutes, so this patient saying, you know, doctor, I cannot reimplant it. So he come to you when you have the tooth in your hand, you clean the tooth, make sure you don't touch the root, you clean just the crown, make sure everything is good. And this is important. So you should irrigate the socket with sterilized saline, like the socket for the missing tooth. You have it now in the medium, and you leave the tooth in the medium while you're doing this. So patient is here, you make sure the tooth is good, you look at it. If you see any like debris stuff like debris or contamination over the tooth, you try to clean it and leave it inside the medium. You look inside his mouth, you give him freezing without vasoconstriction. We're gonna speak about this later. And then irrigate the socket with triasaline. Examine the socket. If there is no fracture of the socket, it's good. So you remove the coagulant because like it's almost 6 minutes now, so there's for sure some coagulant inside the socket. And then you do irrigation with saline and then reimplant the tooth slowly with slight digital pressure. Stabilize for 2 weeks. I'm not going to read it again. I think you can know it now. Suture if needed. Antibiotic is recommended here. Antibiotic is recommended here. And the third scenario, if extraoral more than 60 minutes. So you say, no, I'm not going to do reimplantation here. No. As we said before, delayed reimplantation has a poor long-term prognosis. The expected outcome is ankylosing related replacement or root resorption. The goal of reimplantation in these cases is to restore, at least temporarily, aesthetics and function while maintaining overall bone contour, width, and height. So even if it's more than 60 minutes, you asked him to do it in a cup of milk, of anything, and he comes to you after 60 minutes, you should do reimplant. The decision to reimplant a permanent tooth is almost always the correct decision, even if the extraoral dry time is more than 60 minutes. Again, I will read it. The decision to reimplant a permanent tooth is almost always the correct decision, even if extraoral dry time is more than 60 minutes. Unless, as we said before, the tooth has severe periodontal breakdown, has a huge cavity, patient is immunocompromised, or has some medical condition. Okay? Okay, so we're gonna speak again the same scenario, but like if the tooth has open apex. The tooth has been reimplanted by the patient, amazing. If he's good, you give him job offer, you are happy, everyone is happy, supply the tooth for 2 weeks, and then you bring him back to do root canal? No, because it's an open apex. If it's open apex, you cannot do root canal treatment. And here, this is like, honestly, for me, it was shocking fact, but like it's mentioned clearly. Pulp revascularization, which can lead to further root development, is the goal when reimplanting immature teeth in children. The risk of external infection-related inflammatory root resorption should be weighted against the chances of revascularization. So the goal of reimplanting immature permanent tooth for the tooth to be, again, this is weird. If a spontaneous revascularization does not occur, epixification, bulb revascularization, or revitalization or root canal treatment should be initiated as soon as pulp necrosis and infection is identified. So to wrap it up for you here. So before we said like, okay, we do reimplantation, we book him back after 2 weeks to do RCT. No, if it's immature, you don't do. In immature, you just wait. What you are waiting for? You are waiting for revascularization. Unless you have clinical picture like swelling, pus, fistula, X-ray change, you should intervene. Otherwise, you should wait. In immature teeth with open apex, there is a potential for spontaneous healing to occur in form of new connective tissue with a vascular supply. This allows continuous root development and maturation. Hence, endodontic treatment should not be initiated unless there are definite signs of pulp necrosis and infection of the root canal system at the follow-up appointment. Okay? Second scenario, if the tooth has been kept in storage, physiological storage medium, or stored less than 60 minutes, he come to you, then you should check, give him freezing, irrigate the socket, remove the soft tissue, re-implant the tooth with your digit, and then stabilize it for 2 weeks. Revascularization might happen again, same scenario, but like it will be less likely to happen. And extra oral time more than 60 minutes. I know it's very boring to say it again and again, but I think this is in our culture it's a good to say it again and again. It make it deep, dig deep inside your mind. I remember one of our instructors before, he used to say, if I just tell you, okay, why you wasting my time? You 30 minutes to read this all. You can tell me that's 1, 2, 3. I'll do this. You go. Okay, so I can tell you 1, 2, 3, and you are happy now. 10 minutes later, I will ask you. You will know nothing, or at least you will give partial the answer. But like reading it loud, I'm giving you the information. Reading again and again, it get deeper in your mind, and I hope you will retain it to the exam. Revascularization of pulp space which can lead to further root development and maturation, is the goal when reimplanting immature teeth in children. Again, late reimplantation has a poor long-term prognosis. The periodontal ligament becomes necrotic and is not expected to regenerate. The expected outcome is ankylosis, but it should be done anyway. As I mentioned before, this is almost always the line of treatment we're gonna do. Antibiotic. The best treatment for an avulsed tooth is immediate reimplantation at the site of the accident. Again, this is very good point and important point. Okay, and then once the patient arrives at the dental or medical facility, pain control by means of local anesthesia is always recommended. So we're giving him freezing, but as we mentioned before, without epinephrine. Why? Hence, there is a little evidence to support omitting a vasoconstriction in the oral maxillofacial region. So the rationale here is we are aiming here to do vitalization for the tooth. So how come you're giving him freezing with epinephrine, which lead to delayed or interrupted blood supply to this area and less blood supply to this area? So honestly, this is so sophisticated, but like here, the bottom line here is little evidence to support omitting vasoconstriction in the oral and maxillary region. Regional anesthesia, like infraorbital nerve block here, may be considered as alternative to infiltration. Just if anyone asks you about this, you know the rationale about it. Okay, systemic antibiotic. The periodontal ligaments of an avulsed tooth often become contaminated by bacteria from the oral cavity storage medium or the environment. So therefore, the use of systemic antibiotic after avulsion and reimplantation has been recommended to prevent infection-related reaction due to decrease of the occurrence of inflammatory root resorption. Amoxicillin or penicillin remain the first choice due to their effectiveness on oral flora and low incidence of side effect. Before, we used to use tetracycline and doxycycline because it's more effective, but tetracycline or doxycycline are generally not recommended for patients under 12 years old because it's the risk of discoloration of permanent teeth. So if the children is like young, that's why we stopped using tetracycline and doxycycline. So anyway, avulsion, you give antibiotic, it's amoxicillin, not tetracycline or doxycycline. If a question asking you why we avoid using them, because like usually this happens for young patients, so it will give him more problem with discoloration for the other teeth. Tetanus is not important. They like slow, like he didn't mention anything here. Even the reference he mentioned at the end, it didn't say anything about it. Stabilization, avulsed teeth always require stabilization to maintain the implanted teeth in its correct position, provide patient comfort, and improve function. This is the answer. Provide patient comfort. Provide patient comfort. Short-term passive and flexible splint to be used. It's a stainless steel wire. As we mentioned before, the number, you should know it. If you don't have a stainless steel wire, so nylon finishing line to be used. We use the splinting from the labia surface to avoid occlusal interference and to enable palatal or lingual access for endodontic procedures. This is very critical. Critically important to keep the composite and bonding agent away from the marginal gingiva and interproximal area to avoid plaque retention. It's very important for this to be mentioned here. Okay. So at the end, we're gonna wrap it up here. Endodontic treatment is indicated teeth with closed apex. Treatment should be initiated within 2 weeks post reimplantation. So anyway, if it's closed apex, you will come back to do root canal treatment. When he come back to you, calcium hydroxide is recommended as intracanal medicament for up to 1 month, followed by root canal filling. So when he come back to you after 2 weeks, you do access, you put calcium hydroxide, you wait. If the patient has signs of pain, if a corticosteroids antibiotic mixture is chosen to be used as anti-inflammatory or anti-resorptive intracanal medication, it should be placed immediately or shortly after reimplantation and left in situ for at least 6 weeks. So if you want to give him like more, but I think this is too much. Like in the visit of reimplantation, you open the tooth and you put the mixture inside to decrease the chance of ankylosing here. In teeth with open apex, spontaneous pulp revascularization may occur, thus root canal treatment should be avoided. So to wrap it up, it's 5 or 6 points that you should keep in your mind. Base treatment for avulsed tooth to be reimplanted immediately. If patient cannot do it, he store it in a medium. Most likely it will be milk. Milk is the most preferable solution to be done it. When he come to you, you give him freezing with no anesthesia, with no freezing with no local vasoconstriction, epinephrine, and then you reimplant it. You do flexible splint for 2 weeks, and then semi-rigid splinting. He come to you back. You do the splinting from the labial side, not from lingual side, because you should start root canal treatment. And anyway, you're gonna give him antibiotics for this one. I think that's all. I hope this one was short and condensed. Everything mentioned here is extremely important. You will find some question, some people giving answer which is not reliable. I think with this video, I hope everything is clear. The 3 articles, I tried to do it in one shot. I will divide it to 3 videos so you can watch it at your convenience. Make sure to watch them all, get your notes. Feel free to give me feedback and write your comments. Feel free to share this video with other dentists going to the exam. And I hope that was good for you. Have a good day.